afternoon, everybody. So welcome to Skills for Med. So we'll start now. Today, it's April 1st week, and today's webinar theme will be Elevating Standards to Achieve Excellence. And the topic is going to be about pressure ulcer management made simple. So this is going to be an interactive discussion between me and Dr. Pari. So Dr. Pari Valavan Rajvelu, he is a consultant surgeon, Sundaram Medical Foundation, and he is the founder for Skills for Med. And he is a great champion for the nursing empowerment. He is not just focused towards training the nurses towards the clinical expertise, and also he is focusing nurses into transitioning into the leadership role through the structured program. So before getting into this topic, so we'll start with a scenario. So here is a patient named Mrs. Lakshmi, 72 years old. She is a bedbound patient with diabetes and post-stroke weakness. She had admitted to the general ward. So after 5 days of admission, she developed a stage 2 pressure ulcer over the sacrum. So this is the condition of the patient. So what went wrong? So I'm putting this question to the audience. So where you can drop your answers, what should have went wrong with this patient? She got admitted after 5 days. No, she have developed stage 2 of pressure ulcer. So you can leave your answers in the comment box.
We're trying to get your participation more, so please jump in and put your opinion in the comment box. I saw in the poll that many of you are already doing fantastic work, so we'd like to get your opinion.
They have started to answer. Tilakvati have answered immobilization, and one answer is about because of no changes in position failure. Again, the same answers. So she's bedridden, moisture, unclean linen. That is the reason. Skin safety protocol not maintained, and poor positioning and glycemic control. And no airbed would have been provided. Risk assessment is not done. So that is an answer. And patient was not positioned and examined properly. Nutritional needs are not assessed. So you're on mute, sir.
Now, somebody also answered about nutrition.
Yes. There is another answer. Maybe patient is on prolonged bed rest. That's why patient didn't getting repositioned.
Yeah, I think all these are very important reasons. Thank you. Thank you so much.
Yes, sir.
For answering, and so glad that so many people have answered it, and the comments are still coming.
Yes,
Dehydration is one, not examined routinely, knowledge deficit, diabetes. No, majority saying that assessment is not done.
Yes. So we'll get into the. Yes, sir. Yes. Thank you, everybody. So we'll get into the next thing. What would have went wrong? A common pitfall for for this patient, what would have went wrong is like all the answers has been collaborated here. We have brought into the common pitfall is like not performing a pressure ulcer risk assessment for this patient. So at times the patient comes for the admission. With the initial assessment chart, you have to supposed to carry the pressure ulcer assessment chart with you. And there might be a reason why this patient have developed pressure injury, not recognizing high risk factors such as immobility and age. Those are the questions you have to ask. You have to ask the question to the family members and to the patient, how often they move out of the bed. If really that patient is like so sick, and you have to ask such kind of questions, and not repositioning the patient regularly. You have to maintain the position chart. So that is 2 hourly once. The doctor, what they have advised, you have to reposition on the time rightly, and regularly you have to monitor them, and not responding promptly to early skin changes. While repositioning, you have to also equally see what all the skin color changes are there, and you have to respond immediately. If any changes are occurring in the skin, so which is like unlike it is not normal, you have to inform immediately, and that is not done properly. Another last final pitfall, what it would be like communicating pressure ulcer risk to the care team. Not communicating actually. So there will be in any hospitals, most of the hospital nowadays they're having tissue viable nurse who will be particularly taking care of the pressure ulcer patients. So for such kind of team you have, make use of them. Immediately if any skin changes is there, you call them and then inform them there is a patient with skin changes, so they will take care of it, making preventing them from the worst condition. So we'll come into the real definition. Like everybody knows the pressure range ulcers or localized damage to the skin and underlying soft tissue. Usually this occurs in the bony prominence. Pressure ulcer will not occur in the heavy cushion area like abdomen or the or the region where the lot of muscles are there. Bony prominences, of course, you have to take care of them. That's where the pressure occurs. And also, there might be pressure also related to the medical devices. For example, the patient is on floatron devices. The cuff, the pressure is too much, and then that would cause the pressure ulcer. And also, even the BP apparatus will be the reason. And to think much more device about in ICU, pressure device, for example, NIV mask. So that is another reason. I am giving just 3 examples for the medical devices. So there are much more devices which causes. The immobility, if the patient is not moving from the bed. So this immobility is going to stop the circulation and cut off the circulation or blood supply to the tissues and to the skin, and it's going to damage the surrounding tissue which causes the pressure ulcer. So these are all the common sites of pressure ulcer. When the patient lying on the supine, these are all the pressure area where the back of the head, shoulder, elbow, and the sacral region and the heel. And when the patient on the prone position, these are all the area like elbow, rib cage, thighs, knees, and toes. And on the lateral, of course, the earlobe. Mostly we will leave off the earlobe region, and that has the minor cartilage which might get damaged, and the shoulder, elbow, hip, thigh, leg, and heel. I'm running quick because most of them will know what are all the pressure areas, but equally you have to see in which position the patient is and which all the area is going to get affected with the pressure ulcer. And this is something in-depth detail about the pressure ulcer, how it is formed. So here, so can I get that annotate? Yes. Yeah. So here you can see, here's the bone. So this is the normal skin cross section, and here the cross section of the skin which just shows how the pressure ulcer are caused. So here you can see the bone. Continuous pressure over the hard surface. Continuous pressure over the bone, and that's full body weight is over the bone, and that bone is going to give a constriction to the soft tissue, where automatically it's going to give the pressure to the blood vessels, where the blood vessels are pinched in. You can see the normal skin, how the bone is, it's easy flow in the soft tissue and the blood vessels on the place. And here in the abnormal thing, you can see the blood vessels are like shrinked in and pinched off. Automatically what happens when the blood vessels are pinched off, there may not be any blood flow to the skin, and the tissues are going to die, and the layers are it's going to get pressure ulcer going to form. It's very easy because no oxygen supply, because of no blood supply. And on the other side, you can see below the skin layer there is a hard surface. Here's a bed we have given. So here you can see a red marking here, the skin, and between the skin and the bed mattress, that is actually due to the friction. That is the skin rubbing against the hard surface. That is the other pressure ulcer. Already the pressure ulcer reason, that is giving the extra weight on the bone and pinching of the blood vessel, seizing the blood supply to the skin. And this pressure ulcer going to get even more worse because of this friction activities. So this is the complete explanation how the pressure ulcer is formed. And this is about friction and shear. Because many nurses I have seen, whenever we say you have to prevent the patient from the friction and shear, you should know what is exactly the friction and shear. Here you can see the pressure. So this is the pressure against the bone. So here you can see the shear. It is like this is the zigzag red arrow mark. This is the shear part, where you can see this is the skin part. Already the friction part I have explained you. So friction is actually rubbing the skin over the hard surface. That is the friction. Here the shear part. So this is all the soft tissues. The skin is in the same place. The tissue alone have been having a zigzag movement. What happens? Skin is sticked onto the same place. The tissues are dragging down. What happens that time? The blood vessels and the skin equally going to have a wear and tear, where the pressure ulcer is going to form. So that's why this occurs mainly for the patients who have tendency to slide. So every time when you go for the assessing, no, for going for the assessment, you can see the patient sliding down from the bed, no, unknowingly. So for mostly, no, you will have all the cushion, all the supportive devices at the foot end, and also you make sure the patients are not sliding down with the supportive devices. So that is no another explanation for the friction and shear.
Yeah, this is an excellent picture. Can you go back to that
Yes,
slide?
sir.
So these three factors, that is the pressure, shear, and friction, are the most important factors you have to look at. So you can see these bony points here. No, so here you can see these bony points. So there, you can see where these are the areas in which the pressures occur, right? And as Stella pointed out, when the patient slides, there is a disproportionate movement between the skin and the underlying fat and tissues. So this shears the blood vessels and causes lack of blood supply. The other is friction, it is like rubbing, the surface with the sandpaper. So all these three are the major factors which cause pressure injury, and you will see later that no, we are actually talking about Braden scale. These all will come into assessment. Thank you. That's what I wanted to say.
Thank you, sir. So now to Dr. Pari. So how to classify pressure ulcers? Because whenever we ask the nurse to stage the pressure ulcer, automatically over the phone, they will have quite confusion. Can you make this clear, doctor, to
Yeah.
everybody?
So now when you talk about pressure ulcers, we first talk about the stage. So the stage is how deep the ulcer is, and the extent of tissue involved. So this is usual picture which we see. But next slide, please. Yeah, so this is the adapted European pressure ulcer advisory panel BO grading tool, which is now being used by most hospitals. So grade 1 is non-blanchable erythema. So whenever there is a redness, when you touch the redness, it will become white, right? So that is just normal, inflammation of the skin. But if that redness does not become white, so that is known as non-blanchable. Okay, so that's whenever now you touch on the redness, it doesn't become white. That means it is the starting of the pressure ulcer. So that is the grade 1. There is discoloration of skin. There is some warmth, some edema around. There also may be some induration of hardness, but basically when you touch that, it doesn't become white. So that is the first stage of first grade of pressure ulcer. The second is grade 2 is partial thickness involving the epidermis or dermis. So the ulcer is superficial. So the second is an ulcer is formed. The stage 1, there is no ulcer. It is just a redness. Stage 2, grade 2, the ulcer is formed. The ulcer is very superficial and involves just the epidermis and dermis, and it does not yet reach the subcutaneous fat. Next slide. So grade 3 is full thickness involvement involving the necrosis of subcutaneous tissue also. The fat also is involved, and but not the underlying fascia. So that is grade 3. And grade 4 is extensive destruction, tissue necrosis or damage to the muscle, bone, supporting structures. So usually we see this in the buttocks and other areas, very deep thing going up to the bone. So that is how you grade the pressure ulcers. Next slide. Yeah. So I wanted to ask you, how would you identify the patients who are prone to pressure ulcers? Not after the ulcer forms, but who are prone to them.
Yes, doctor. It is very important to you have to first know which role the patients are prone for this, so that we can know early identification is better. Mostly, this is for bedridden patient and the patient who sit on a chair or wheelchair for a longer period. So then no, they'll have a limited mobility. And how to perform pressure ulcer risk assessment for this patient. So you should raise clinical judgment questions for the patients during the time of admission. As I have said earlier, ask the patient for skin problems or ulcer. Do you have any earlier issues related to pressure ulcer or any skin damage? Sometimes they'll have some dryness over the skin. So if such kinds of there, then you have to perform comprehensive skin assessment. And points to remember during the skin assessment check is like, you have to check the bony prominences, and you have to check the pressure ulcer, lesions, and excessively dry skin, moisture associated skin damage will be there. Because these are all the things you have to remember when you're doing skin assessment. And also assess the patient using a validated scale. You don't have to memorize everything. I have said in the earlier previous slide, you have to remember bony prominence, pressure ulcer, lesion, excessive dryness. All these things you don't have to memorize. You should have a validated scale to assess or to perform the pressure ulcer for the patient. So validated risk assessment scales are like, you have Braden scale, which is largely used, and fragment pressure score, Waterloo score, and Notion risk assessment scale. Here in this webinar, we'll be exclusively seeing about the Braden scale, which is largely used in many of the healthcare organizations. And also, I would recommend, please use the scale that is recommended by your hospital. And pressure ulcer risk assessment will be done at the time of admission, as I have said, and also at any changes in the clinical condition, you have to do the pressure ulcer risk assessment. It's not that you have done during the admission, then it is enough. Patient is not prone for it. You have to do every time whenever the patient have some changes in the clinical condition. And I need to show you what is actually the original Braden scale looks like. This is the original Braden scale. We are not going to deep dive into this, where all the audience can see how it is too complicated. So text, no, many text are there for read, no, to read out. I have seen many nurses who have found difficulty to adapt to the scale, because they just go do the positional change, and then they will not be scoring the patient in a right way, because this is too complicated. And that's where there is a Braden scale, which is very simple. It has been implemented, where it will be like having a subscale of sensory impairment, loss of consciousness, and it has a scoring still 4, where the patient, if it is fully conscious, we're going to score them with 4, with no sensory impairment. They are normal patient who can mobilize. And then for the score 3, for the patients who responds to verbal commands, and score 2 will be given to the response only to the painful stimuli, sensory loss over of a body. And score 1, yes sir.
I'm going to describe that in detail. No, I
Okay
think
sir,
let's
done,
not
done.
get into that
Yes,
here. So
yes,
the reason we put these two, the Braden scale, original Braden scale, and this is, and this Braden scale is actually done by Skills for Med. It is
yes,
simplified. Okay, so it is easy for the nurses to quickly read off and understand what is there in every aspect of the subscales. So that is the reason we put these two slides,
yes,
show that how it can be actually simplified. It's, I mean, nothing uh, great about it, but it's just that, you take the initiative to make sure you without losing the meaning, you can simplify the scale so that you can still get the meaning. Okay, so that is what
yes,
we've done. So it is easy for the nurses to check this out, and we have actually implemented in a few hospitals whom we trained, and they find it very, very useful.
yes. Yes, yes, doctor. You can take this turn now to perform, like how to perform the pressure ulcer risk
Yeah.
assessment using the
So
Braden scale.
using the scale, now how do we go about it? That's what we're going to discuss. I think there are only two important things in this webinar we're going to discuss. One is to make sure that every one of you has a good understanding of Braden scale. As Stella said, you don't need to memorize it, but when you go through the scale, you should know how to interpret it. So next, have the next slide.
Yes,
Yeah, so it is a simple scoring system, though it looks pretty complicated when you look at all the tables there. So it has got individual subscales. So there are six subscales, which we'll talk about in the first column. And each of them is graded from 1, which is the highest risk, and 4, which is the lowest risk. And the total score calculation from each subscale is added up. All of them, is pure arithmetic. You just add them up from 6 to 23 will be the range of score you will get. Then, based on the score, you assess the risk level. So, if it is very low, then they are very high risk. No, and if the score is high, there are low risk. So that is how, this is a simple thing which you have to understand. Next slide. So let's look at the six key subscales. The first is loss of consciousness or sensory impairment, moisture, level of activity, level of mobility, friction and shear, and nutrition. Okay, so I think Braden scale is so comprehensive. When we asked the first question, what do you think are the causes of why this patient developed ulcer? You would have found in the comment all these things have come in. So that's the reason we asked that question, just to make sure you understand why Braden scale is involved, included all this. With experience, you will know that these are the main reasons why pressure ulcers happen. Either the patient is unconscious, has got sensory impairment, so then they don't feel the pain, which a normal person will feel when you put pressure. When you sleep, you sometimes put pressure on the bone, and then it makes you, it wakes you up, and then you turn your position. A normal person will do that. Whereas if somebody who's got sensory impairment or loss of consciousness will be unable to do that. So is the patient aware of the pain or discomfort? That is what this is asking you. Then the moisture is, how often is the patient's skin exposed to moisture? So is it constantly moist or no, less moist? We'll see that. Then activity. So how mobile is the patient? Is the patient bedridden or walking? So this difference between activity and mobility should be understood. Activity is getting up and walking, okay? Whereas mobility is within the bed, how they can turn themselves around independently. That is mobility. And then friction and shear, I think Stella explained beautifully. So is the patient sliding? That is the shear, and or is it causing friction? That is the rubbing action. And nutrition is the patient adequately nourished. So without nutrition, the skin will break down. So that is why these six key subscales are there in Braden. Next slide. So let's look at a level of consciousness. What it means is the ability to perceive pain or discomfort. Why? Because a patient unable to sense or communicate, sense is one. Communicate discomfort because they may be aphasic. No, they are at a higher risk of pressure ulcers. Next. Next slide. So
Yes,
moisture. So the skin's exposure to moisture. Why it matters is constant exposure to moisture will cause what is known as maceration. You will find that the epidermis becomes edematous and it is easily prone to breakdown. So that is why moisture is important. Next slide. So you have to keep the skin dry and clean. That is why this is being there. Then the third is the activity. So how much they are up and about, are they walking? So bedridden patients are higher risk due to prolonged pressure. So it is very, very important if the patient is capable of encourage regular movement, get them out of the bed and make them active. And the next one is mobility. Mobility is the ability to change positions in the bed itself, independently. So it increases, if you're immobile, then it increases the pressure on certain areas leading to skin breakdown. So that is why we say change the positions, every 2 hours, change the position of the patient. So that is where you encourage mobility. And the subscale 5 is friction and shear. So this we already discussed. These forces will damage the skin and you should use proper repositioning techniques. And the last one is nutrition. So nutritional status impacts the skin health and it slows down skin healing and increases the ulcer of pressure ulcers. So you have to give the patient a very nutritious and well-balanced diet. So this is about the subscale. So now that this is understood, let's get into the scale itself. Next slide. So we need to apply, when to assess. All patients at admission needs this assessment. When do you reassess? When a patient's condition changes or as required by the hospital policies. In the ICU and IMCU, where the patient may be unconscious or unable to communicate every 24 hours. In the ward, usually the hospitals have a policy of weekly assessment after the first assessment. But if there's any change in clinical condition, then definitely much more often. Time required to use the Braden scale is only 10 minutes. Though it looks complicated, it doesn't take that much time. And equipment, there is none. It is just using this pen and paper and observation, you can finish the Braden scale in practice. Next slide. So, Stella, once we identify the risk, what simple actions can prevent pressure ulcers effectively?
yes, sir. So there are some strategies to prevent the pressure ulcers. So I'll populate everything first and then I'll start off. So assess regularly. So that assessment is very important. As Sir have said, you have to follow your organization protocol on assessment, and also change on any clinical condition. The frequency of assessment will varies, and initial assessment will start during the time of admission. And also you have to have a track on how you're going to assess the patient. Not just like that, you're assessing the patient and come out, you ask certain questions to the patient, and you have to reposition the patient every 2 hourly once. You have you ever been asked this question, why every 2 hourly once the position has to be changed? Not why not every 3 hours? Why not every 4 hours? Because the skin can allow the 2 hours. No, after 2 hours, if it's exceeding 2 hours, actually the skin is going to be the oxygen supply is going to get reduced in that particular area, and that is going to cause the pressure ulcer. That's why without extending more than 2 hours, we have to change the position for the patient. That is the ideal behind why we are insisting on 2 hours. And you have to provide the skin care. If you have collected the proper history collection, the patient would have said the patient has a dry skin, then that is also going to be another contributing factor for the skin breakdown. So you have to ask to the doctor and immediately give them some moisturizer, and during the back care you have to give extra care to the patient, to all the skin wherever the patient has some dryness, and also provide balanced diet. What is the point of balanced diet when it comes to pressure ulcer? It is not about you just go and ask them how the patient had the food. Did the patient had breakfast? Did the patient had lunch? Doesn't serve anything. You have to ask them whether the patient, how much the patient had, and what all the kind of food the patient had. Because balanced diet is something about all the nutrients should be there. Zinc, iron and the protein, everything, because all the nutrients, individual nutrient has individual role. Even for example, for vitamin C, if the patient is having then the patient is going to have a good wound healing. So that's how you have to take care of the patient in asking such question about whether the patient had a balanced diet, and offer supportive surfaces. If in case the patient is continuously sliding down, which is actually the shear action, and then the patient will have the pressure ulcers. To not provide that, you have to give the supportive device. First supportive device is going to be the bed, air mattress. See, if you think that patient is more prone for or risk to develop the pressure ulcer, then you have to ultimately order for the air bed and provide that immediately. And for the sliding patient, you are going to give extra cushion at the foot end, because they will not come and touch to the foot end of the bed, which is again going to cause them pressure and which lead to the worst pressure ulcer. And also some cushion pads. If you are putting the patient on the prone position for any treatment modalities, and you have to give extra caution towards the chest region, the rib cage region, and the knee, and towards the foot region, you are going to give extra cushion using the gel pads, for example. And also I have seen not all, for all the patients in the ward, you will be giving the gel pads, you will be having the water balloons filled to give the extra cushion effects for the patient. And ensure the mobility within the bed. The patient, how many times they are moving. If the patient is conscious and they are able to move, tell them you can move in the bed. You can know every 2 hours you can go and remind them, telling them this is the time you have to move yourself. You have been since long you have been in the supine position, turn to the left, turn to the right, like that. If the patient is not able, they need the real assistant, tell them the call bell is near you. If you need any help, you can call us. And then every 2 hours, what my senior leader have said, sir, when I started my career for the pressure injury prevention, taking care of all the patient, it was very difficult for me to change the position for the patient every 2 hours. Really, I will forget with all the core of works. What my great leader have given me the advice I would like to share here. You can keep alarm in your mobile phone, not in your personal phone. Every ward will have a CUG. Your ward phone mobile will be there. You can place the alarm saying with your name, change the position, so that you have 5 nurses in your unit. With your name, change the position, automatically your team will alert you saying, Stella, it is your time. You go to the room number and you change the position for your patient. You can ensure mobility for that patient, because it's very important in case of preventing the pressure injury. And ensure the hydration. The patient, as far not restricted for the liquid intake, you can advise them to take adequate water And you can even ask them, and you can even have the cross check. No, morning you would have given 2 bottles. In mid time, you can go and check how much they have consumed, and you have to tell them importance of hydration. And that will nourish the skin, and it will prevent them from the skin dehydration, and also prevent from the dryness, and provide patient education. That is again important. So as in the poll we were asking the question, asking the patient is sleeping, how I'll be moving the patient. You have to educate at the earlier time, like during the time of admission, when you're doing assessment, and you have found that patient is more prone for pressure injury. You have to educate the patient that how often you will come and change the position for the patient. Please bear with us. Every 2 hours once, I am going to be inside your room. I am going to change the position for you. I will not leave you under risk for the pressure injury. These are all the things you have to educate the patient, and also equally to the patient family. And monitor the skin condition. We even go change the position and come back. That is not actual mechanism of work. You go change the position. Every time changing the position, you don't have to do the bread and scale. Sir have very clearly explained when you have to do the bread and scale. But for your thing, what you have to do, other than that, you have to do the visual observation on the skin. Like you have to monitor the skin. You have to be vigilant. You change the position, ask the permission from the patient, release the gown. For example, you're putting the patient on the lateral side from the supine. Tell the patient you're going to have a quick glance on his skin. So on the lateral side, remove the gown and see whether any skin changes. Morning, you wouldn't have noticed anything. Meanwhile, in 4 hours of time, or at the end of the shift, after every 2 hours you have monitored, at the end of the shift, when you're giving handover, you're at the time of changing position, there might be small color changes in the skin. So that's the place where you have to promptly inform to the skincare team. And lastly, avoid friction and shear. That is very important. We are responsible for the patient, and the friction and shear while shifting, always have a count. Pressure injury prone patient, do not use the slider board. Always have a count within yourself. Get help from the assistants, and then n number of patient, like depending on the patient weight, you know how many patients must be involved in shifting the patient. Count, lift and shift. Don't drag the patient. That causes rubbing over the surface friction. And if you see that patient has a tendency to slide down the bend, and then that is going to cause a shear effect, and you're going to give comfortable devices, cushion pads all around, so that the patient will not have any pressure injury. If you follow all these 10 steps, 10 strategies, and you can prevent the pressure ulcer ultimately.
That's great. I think, no, very good summary of prevention of pressure ulcers. Thank you.
Thank you, doctor. And to you, doctor, I have heard about time, and this time framework is not familiarized among many of the healthcare professionals in wound care. So, can you please explain how it is used and what it is actually?
Yeah, actually, this can be done as a separate webinar, but within the given time, let me just quickly understand, what time means and how do you go about it. So next slide. Okay, so it was developed in 2002, early 2000s, by a group of wound care experts. And it is actually proven to be a practical guide for managing, patients with wounds. So the time, each word, letter stands for a particular aspect of care. T stands for tissue management. I stands for inflammation and infection control. M for moisture balance, and the M for moisture balance, and E for epithelial edge advancement. Okay, next slide. Can you move to the next slide? Yeah. Okay, so a little bit of detail about each. So T is tissue, management. So basically, it applies for both acute wounds as well as chronic wounds. So basically, your assessment, you ask whether the tissue is non-viable or there is deficiency of blood supply. So these are the two things which you are going to ask in the tissue part of it. I is both infection and inflammation. So inflammation just could be just the reaction to the ulcer, though there's no infection. And of course, infection is when they are contaminated with bacteria. And M is the moisture. So moisture is, we already saw how important it is for the ulcer formation. And it has been proven that when there is an ulcer, the healing of the ulcer is also dependent upon the moisture balance. The key word is here balance. Neither too much of moisture, nor too little moisture. Both are harmful. So is there too little no moisture? That means the no ulcer is dry, or is the moisture too much? That means if the exudate of the ulcer is too much. So then E is epithelial edge management. So you can see here, this is the epithelial edge. Let me get the annotation tool. Yeah. So this is the epithelial edge, no, the edge what we're talking about. So this edge is very, very important because that is the healing tissue. So many often, no, patients come to my clinic saying that, I have had this wound and it's not healing for about 3 weeks or 4 weeks. And what is happening is the uh, the epithelial edge when it grows, it forms a thin tissue paper like white tissue. No, there's only one single layer of epithelial tissue forming over the ulcer, especially if it's a nice granulating wound. And people think that this white is a dirty thing, and they will rigorously rub it and remove the epithelial tissue, and that is why the wound doesn't heal. So what I will do is I will just put a dressing, which absorbs moisture, something like, or also gives moisture, which maintains a moisture balance. This any of these, latex dressings. Restore is one of them. Keep it covered and say, put a nice bandage around it, and then say, come and see me after 5 days. The patient will get very, anxious. Sir, I don't need to do any dressings. No, no, don't do any dressing. Just keep it covered. No, don't disturb the dressing. Just come and meet me after 5 days. 5 days, I remove the dressing, and lo and behold, the ulcer is healed. And that patient thinks I'm a magician. So what we have done is, now we have just, now there is a concept in wound care called undisturbed wound care. So
Yes.
when the wound becomes red, when it's nicely granulating, just don't disturb it. The epithelial tissue edge will all keep forming. Very, very important to understand this edge. If it is unhealthy, yes, of course you got to do it. But if it's healthy, just don't do anything. No, don't disturb it. It'll it's trying to do its job. So these are very, very important. So you don't want any tissue which is non-viable or which has got very low blood supply. You don't want any infection or any inflammation which is preventing the ulcer healing. You don't want too little moisture or too much moisture, and you want to see whether this edge is unhealthy, then only you will intervene. So this is very important to understand, and that is the reason time management has become a very useful method to manage ulcers. Okay, so next slide, please. So application, as I said, it can be used for both acute wounds and chronic wounds. So chronic wounds, you want to heal them to heal. Acute wounds, you don't want them to progress into chronic wounds. So for this, the time framework can be used. Next slide. So let's look at each one of these. Let's put the whole slide. Keep clicking. Yeah, that's fine. That's fine. Let's get into, go back. So first we'll focus on tissue. Yeah, one more click back. Yeah, that's good. Okay, so when you look at the tissue management, so you can actually classify. This is called the traffic signal or management. I mean classification of wounds. So here you see it's black, then there is yellow, then there is red, and or you can say pink, and then the white. Okay, so black is necrotic, yellow or green is infected and slough, this bright red is granulating, and the pink or is the epithelializing tissue. So in our skin color, it doesn't become pink. It actually becomes a little bit opaque sort of thing. Okay, so it's very, very important. As I told you, these two don't intervene. When I talked about undisturbed wound care, it is only for these two. That is the granulating wound and the epithelializing wound do not intervene. It is not, no, that, and just do the appropriate dressings. Whereas in infected slough, you may need to intervene. Necrotic, definitely you need to intervene. So the infected slough, you can either use chemical debridement or actual surgical debridement. and use the appropriate dressing to make sure this slough and the exudate is being absorbed properly. Okay, so that is the tissue management. Next, let's go into the intervention. So intervention could be again in granulating epithelial undisturbed. Don't do anything. Don't put any ointments. Don't put anything. Just leave them alone. Just wash them with saline. Keep them clean. Just normal hygiene they will do. But in these two wounds, you have to if the wound is infected, antibiotics. If it is just inflammation, you can give local antiseptics and ointments. If there is a infection, IND, if there is a lot of necrosis or no slough, then you need to do debriding physically, or you can do debriding agents. So these are the interventions and where you have to use it. Next, let's go to moisture balance. So moisture again in these two ones is important. No, when I say no intervention, now maintaining the balance is important. Not too much, not too little. Okay, so there are several dressings which will do that. Normal gauze is not a good thing because it gets dried up, very easily. And definitely, not using like iodine, but that is betadine wash or hydrogen peroxide wash is very toxic. And now iodine actually is very harmful to the granulation tissue, and hydrogen peroxide, that oxygen it releases, is actually toxic to the epithelial tissue. So don't use these things in these two wounds. In fact, many countries have banned hydrogen peroxide and povidone iodine wash on the wounds because they feel that people just keep using them indiscriminately and it prevents healing. Okay, so moisture balance, you can use proper dressings, saline, wash and keep it. Whereas when high exudate, you need to use absorbent dressing or negative pressure, WAC dressings. Whereas if it is low exudate, you have to provide moisture. So this is where the newer dressings are very useful, where they can provide moisture. I can't go into details about about the real dressings and all that, but I'm giving you the overall framework. Finally, the epithelial edge management, which is E. So if it is unhealthy, that is in these two, you debride. If it is healthy, you protect. Simple. Okay, so this is how the time management works. And as I told you, with the limited time, I've tried my best to explain it very simply, how this whole time framework works. So as I was going through this webinar, two courses come to mind. One is a tissue viability nurse course, which could be a long-term course for nurses to actually specialize. And the other thing is a wound management, maybe a half a day or 1 day workshop, which you could do. And
Yes, sir.
could actually, see if how many people will be interested in that. Okay, so this is about time wound management. I hope this was clear to you. Next slide. So I think that is what we have got to cover today. Please, Silla, if you
Yes,
don't
sir.
summarize today's webinar.
Sure. So, summarizing to this, like pressure ulcers are preventable with proactive care. So, we have given a lot of, like how you have to do the risk assessment for the patient. The Braden scale has been explained clearly. So, it is about performance risk assessment using tool like Braden scale. And again, based on your organization, if you use some other tool, then you have to catch up with such tools when you get the patient prone for the pressure ulcer, and adopt strategies such as regular repositioning, moisture control and good nutrition to prevent pressure ulcer. We have discussed in depth about that, and use evidence-based framework like time for wound management. I think as sir said, we will have an exclusive session about this time.
Thank you so much for your attention.
Yes, thank you so much, sir.